said, the talk going to be on the measures to mitigate the blindness from glaucoma. I think in the absence of our chairman, Professor S.K. Satish, we want Professor J. Srinivasan. He is the founder of the VHS Climate Change and a past chairman. He was the Emeritus Distinguished Professor of the VHS Center. And also he is the lead author for the second and fourth International Policy on Climate Change report on climate change, and also reviewer of the, and also editor of the third report. And he has his major scientific contribution mainly in the area of monsoon models and the climate change. He received the Lifetime Achievement Award by the Ministry of Earth Sciences in 2019. And as I know, for the past 3.5 years I know him. He's a man with certain values, disciplined, simplistic way of life, with helping hand, with academic zeal to propagate the knowledge. It's a great honor to have him here. I request Professor Srinivasan formally to welcome the people.
Thank you, Dr. Paramesh.
Yeah.
On behalf of Professor S.K. Satish, Chairman, Division on Climate Change, I welcome you all to the monthly program, which Dr. Paramesh organized without fail. And this program brings eminent doctors to talk about the important issues related to environment and health. And today we have a very important topic. Glaucoma is a very unusual disease because it's very silent. There are hardly any symptoms, and many people, when they go past 60, develop this disease without knowing it. And I know it personally because my father suffered from glaucoma-related blindness for 20 years. So I know how important it is to get tested regularly and to be aware of this condition. So I'm very thankful to Dr. Paramesh for arranging this talk, and I hope everyone will get valuable knowledge about the nature of this condition. Thank you, Dr. Paramesh.
Thank you very much, sir. And next is making some introductory remarks on the subject, and before introducing the speaker and the chairman. Right after that, we are going to all of you switch on our the picture, so our camera, so that we have a picture. So it should be published every our bulletin. So now, as we are talking, glaucoma is the raised intraocular pressure from more than 22 millimeter of mercury damaging the optic nerve and the vision. It has been estimated it is the second leading cause for blindness. 1 in 200 people under the age of 50 years can have it. 1 in 10 people over the age of 80 years, you can have this glaucoma. And as Professor Srinivasan mentioned, it is nicknamed as a sneak thief of sight, since the loss of vision occurs gradually over a period of time. The untreated glaucoma leads to permanent damage and visual loss and blindness. My maternal grandfather died from the with glaucoma only, developed complete blindness. So he was waiting for me to come from United States to take the good doctor. He didn't listen to his family doctor. So if the condition is recognized early enough, one can arrest the development of glaucoma and also the progression. In addition, some tips we can use in our lifestyle. How can we reduce our eye pressure? These are all the things we are going to learn from now. To talk about this important subject, we have a person with a lot of experience. That is Dr. Jyoti S Shetty. Dr. Jyoti Shetty is a very well established consultant in ophthalmology with over 23 years of experience in cataract, refractive surgery, and glaucoma. She is the postgraduate teacher for Diplomate of a National Board of Examination for specialization in ophthalmology since the year 2001. She is a mentor for fellowship in Phaco, refractive surgery and glaucoma recognized by Rajiv Gandhi University of Health Sciences, and since 2011. Dr. Jyoti Shetty is the principal for the course of Diploma in Ophthalmic Techniques, recognized by the Government of Karnataka. She has delivered various lectures extensively and published at local, state, and national level in her subspecialty over the years in peer-reviewed journals. She has training in laser system, Hong Kong 2003, training in the Phaco ACL, Munich, Germany 2003, training in the pediatric glaucoma, Great Ormond Street Hospital, London 2008. She is the member of the various national, international ophthalmic societies. Currently, she is the consultant ophthalmology at Manipal Hospital, HAL, Airport Road, Bangalore. To chair this session, we have another eminent ophthalmologist. So Professor Dr. S. Shetty, he is the Vice Chancellor, Aditya University, BG Nagar in Karnataka. Formerly, he was the Vice Chancellor, Rajiv Gandhi University of Health Sciences, Bangalore. Sri Devaraja's Academy of Higher Education, a deemed to be university in Kolar, Vice Chairman and Indian Red Cross Society, Karnataka, and Director Regional Institute of Ophthalmology, Minto Ophthalmic Hospital, Bangalore. He had postgraduate doctorate in WHO fellowship in UK, USA, and Australia. He is the member of the various committees in the state, national, international, government, non-governmental organization, and also associated with the National Assessment of Accreditation of Council for the past 2 decades. He is a sportsman himself. He plays shuttle and tennis. He has been a recipient at many state, national, international orations, keynote addresses, innovative lectures, awards, and recognition of his contribution to higher education. And in the community, he has about 45 plus scientific presentation and publication to his credit. And also, recently he received the Lifetime Achievement Award from Ophthalmic Society of India. And the Lions Club International President Certificate Appreciation Awards. He is the Chairperson Certificate Appreciation Award for LCIF Helping Hands Award for his contribution to sight Lions Vision for All in 30 years. So, I know him as a friend. He's another person totally committed for the education and hardworking administrative skills. And now recently he has been appointed as conduct centenary celebration of the Mysore Medical College. We are the graduate. We're all, he's 1 year junior to me. We belong to the same medical college. It's always a pleasure to have him. And thank you very much, sir, to chairing this session. Before you taking it over, we like to have the picture of all of us. Please, all of you who are attending, so put on your camera, please. Let's have a picture before starting the topic. And also we have our international president, Comrade Yashwant Patil is there. So I forgot to mention about it. Yes, thank you. Okay. Pradeep?
Yes, sir. Yes, sir.
It's over now?
Yes, sir.
Okay. So over to Professor Chandrasekhar Shetty. So go ahead and chair the session, moderate it, and let us learn from the speakers, sir. Over to you, sir. You unmute, sir. We cannot hear you, sir. Unmute. Can't hear, sir.
some problem.
Okay, now we can hear you now.
Am I?
Yeah, yeah, now we are audible.
Okay. There's some problem here.
Okay.
And then thank you, Parameshwar and Professor Srinivasan, Dr. Yashwant, and Jyoti Shetty, and all other dignitaries. And without taking too much of time, I request Dr. Jyoti Shetty to go ahead with her talk, and then maybe I will reserve it my comments for the end as chairman and moderator, and we will have it in the question. Dr. Jyoti Shetty, please. And only one word I would like to add with your introduction, and she is the lady who managed the actually Bangalore West Super Speciality Hospital with great success for actually more than 15 years. And this Bangalore actually West Line Super Speciality Hospital is one of the leading Lions Eye hospitals in the world. Congratulations, Dr. Jyoti Shetty. Go ahead.
Slides.
First, I'll unmute. Can you all see the slide, sir?
Yes, we can see the slide.
Is it fine now?
Yes.
And can you all hear me, sir?
Yeah.
We can hear you, sir.
Okay, thank you. At the outset, let me thank Dr. Parmesh for this opportunity. It's an honor, sir. More so in the presence of Dr. Chandrasekhar Shetty, who is a revered guru, guide, and mentor to me. So, real pleasure to be amongst all of you today. A very good afternoon from me. From Manipal, I'm still in the hospital. So I'll just, I'll try and cover all the important points. I understand that the audience is a mixed bag of scientists and public health officials, so and the general audience. So I've tailored my talk to, to be able to be clear to all of them. Now, my outline of the talk would be, I will just describe in short what is glaucoma, what the various types of glaucoma are, what are the present modalities of treatment, what is the global and Indian burden of blindness due to glaucoma and why are we so worried, and what are the measures that we can adopt to mitigate blindness due to glaucoma, who's at risk, and are there any modifiable environmental or lifestyle parameters that can prevent the disease from going into glaucoma. What is glaucoma? Glaucoma is a disease of the optic nerve. Glaucoma is a disease of the optic nerve where the retinal ganglion cells are damaged, and this leads to irreversible blindness. Now, the main proven cause of glaucoma is intraocular pressure, and the normal intraocular pressure can be anything between 10 to 21 millimeters of mercury. So let me explain it into simple terms. This is the normal cross section of the eye. You can see the clear cornea, the lens. This is where light enters inside the eye. It falls on the innermost layer of the eye, which is the retina, the active cells of which are called as the retinal ganglion cells. Stimulates these ganglion cells, and the axons of these ganglion cells then carry this image in the signals in this optic nerve back into the brain, into the occipital cortex area, and that is how we perceive the images of the objects that we see. That is a retinal ganglion cell, the most important part of the retina, which takes part in the process, and the one that is lost in glaucoma. This is how a normal optic nerve looks to us when we have a when we look at it in the eye with the normal thickness of the retinal nerve fiber layer, and this is how it appears in glaucoma, where this area of white goes on increasing, and we call that as increasing cupping. And because of that, then the field starts getting all visual field defects. Sorry, my slides are not moving. Just a second, sir. Are you?
Pradeep?
Yes, sir.
Yeah, Slides are not.
Speaker is not there in the meeting, sir. She left, I think.
No.
I think she must be reconnecting, so let's wait.
Reconnecting, yes.
So do you have her number, sir? So I can send her the link.
Yeah, we have the number.
Pradeep or admin alla?
Pradeep?
Yes, sir.
ಒಂದ್ಸತಿ ಅವ್ರಿಗೆ ಅವ್ರ ಮೊಬೈಲ್ಗೆ ಡೈರೆಕ್ಟ್ ಲಿಂಕ್ ಕಳ್ಸಕ್ಕಾಗತ್ತಾ?
ಕಳಿಸ್ತೀನಿ.
ಕಳಿಸ್ಕೊಡಿ.
Yes.
I'm very sorry. Can you hear me now?
Yeah, we can hear you, madam. Slides have not come.
Yeah, I'll do that once again.
Thank you.
ಬಂದಿಲ್ಲ ಸರ್ ಇನ್ನ ಇವರು?
ಬಂದಿಲ್ಲ, ಬರ್ತಾರಲ್ಲ, ಬೇಡ ಬಿಡಿ.
Yeah, are they there now?
Yes.
Okay. I think do I use you all at this level?
Yes. Yes, madam.
Yeah. Okay. So to put it in a nutshell, what exactly happens in glaucoma is there is raised intraocular pressure, like I talked to you about. It affects the retinal ganglion cells and then damages the axons, and that is the main component of the optic nerve. Now, why does the intraocular pressure rise? There is a fluid that is formed inside the eye continuously, which is meant for the nourishment of the structures inside. This fluid forms, drains out from the angle through a meshwork inside the eye, which is a collagen structure, and it maintains, from there it disappears into the blood circulation. So this is how the intraocular pressure is maintained inside the eye. Now what happens in glaucoma, there is a block of either the drainage in the angle out here, or there is a drainage in a block in the meshwork, and that's how the intraocular pressure starts rising and causing a damage of the optic nerve. And hence, once the optic nerve gets damaged, the signals that go to the brain are then interfered with, and that's how we do not perceive, or we start seeing defects in our visual field. This is what happens in glaucoma. Now, like I told you, either there is a block in the meshwork or there is one subset of glaucoma where the angle of the eye from which the drainage has to occur, from that area the fluid doesn't drain out. It is because it is extremely narrow, which we have genetically inherited, and when this area becomes narrow, then again fluid is not able to drain out, and that's how the intraocular pressure starts building inside the eye. So this is the mechanism by which glaucoma occurs. So this is a normal visual field as we perceive it with both our eyes. And what happens in the initial stages is we start getting these defects in our visual field, which makes us feel as if certain parts of the objects are missing. Please interrupt me if there's anything wrong. Hello, can you all hear me?
Yes, yes, yes.
Yeah. And then as the disease progresses, the entire visual field or your entire vision becomes extremely foggy and blurred. And towards the last stages of the disease, you start seeing in patches or only through small fields of vision because the peripheral field is all lost. And over a period of time, even this shuts down. And what you then start seeing is just through a central tube, which towards the last stage of last stage of the disease disappears completely. And that's how you land up being blind due to glaucoma. It is the field that is lost. And that is why if you just check your vision, you are misguided by your diagnosis. And when we see it clinically, this is what we see. We see a progressive damage of the optic nerve inside the eye, which we describe as cupping. And when we subject the patient to tests, especially the visual field test and the RNFL test, we start seeing a narrowing of the visual field as it is seen out here. It starts from this and then progresses to this stage. I already described to you there are two types of glaucoma. One is an open angle glaucoma and a closed angle glaucoma. Here the angle is open of the eye, but the meshwork is defective. Here the angle itself is defective. And there are many secondary causes of glaucoma where you can get glaucoma because of trauma to the eye, because of diabetic retinopathy, because of inflammations, and because of prolonged steroid usage. The symptoms, as was mentioned before, are largely seen only in the subset of the angle closure glaucoma. The open angle glaucomas largely go asymptomatic till the disease is advanced, and that is why it is called as a backdoor thief. But in angle closure attack, we start with symptoms of seeing colored halos. So if there is a bright source of light, you will see a colored ring around it, and that's your first sign that something is wrong with the angle. And if not treated, then you might then present with a sudden onset of loss of vision with severe pain, headache, and vomiting. And this is sight-threatening if it is not treated early. This is how we diagnose glaucoma in the clinic. We have various instruments to measure the pressure, to look into the angle, to see if it is closed. Then we look at the nerve behind. Then we subject the patient to tests like the visual field testing and the RNFL monitoring to quantify what is the damage, and this then dictates our treatment. Now, the present modalities of treatment, the main goal is to decrease the intraocular pressure. And we start usually with medical therapy, and we have a wide array of drops which belong to different classes to control the intraocular pressure. Remember, whenever a diagnosis of glaucoma is made, it's a lifetime of treatment and follow-up, and hence with medical therapy, the issue of compliance and long-term adherence to the treatment becomes very, very important and crucial. In an angle closure glaucoma, we have a definitive treatment. We can do an additional hole in the iris so that we create an alternate pathway for drainage because the angle is blocked, and we use a laser to make an opening like this, which will take care of the intraocular pressure. We also have another laser that we can use in open angle glaucoma where selective spots are given close to the meshwork so as to cause certain biochemical changes and make the meshwork which is blocked to start working. However, the effect of this is temporary, and it's usually only an adjunct to medical therapy in mild and moderate cases. Now, whenever we resort to glaucoma surgery, when we fail to achieve the treatment or the level of intraocular pressure that we want with medical therapy, if the patient is not adherent to the medical therapy because of financial constraints, physical restrictions, or the dosing regime is extremely complex, if he is intolerant to medical therapy, or we need to achieve a very, very low pressure in advanced disease, in all these cases, we then resort to surgery where either a filtering surgery called trabeculectomy is done, or we use glaucoma drainage devices of the Ahmed valve or the Beerwell valve to control the intraocular pressure. We also now have a lot of minimally invasive glaucoma surgical devices that have been introduced in the market, and they are of various types. Of course, their role is there only in mild to moderate glaucoma. These surgeries need to be repeated often and their cost is exorbitant. So in the Indian scenario, they're not still very popular in treatment modalities at all. This is in short and nutshell about the disease process itself. Now let us look at what is the global and Indian burden of the blindness due to glaucoma and why we are worried. So let us first discuss the burden of the disease and then we'll go to the burden of glaucoma. So if you look at the burden of disease, the prevalence of the open angle type of glaucoma in a meta-analysis that was done in 2020, the global prevalence of primary open angle glaucoma was 2.4%. Now this is very high prevalence for a vision threatening disease. And this prevalence only increases with age. Men are more susceptible and the highest prevalence is seen in Africa, with Oceania having the lowest prevalence. The current estimated global burden of primary open angle glaucoma in people over the age of 40 years is 68.5 million, with over 53% of them being in Asia. If you look at the angle closure glaucoma, which is not as high in incidence as the open angle glaucoma, the global prevalence of the disease is 0.6%. Again, this increases with age. Women are, however, more susceptible, and the highest prevalence is seen in Asia and not Africa. And the current estimated global population of the angle closure disease is about 17 million, with 12 million being in Asia. And it's estimated by the year 2050, this will be about 22.6. From 22.6 million, it will rise. This figure will be about 22.6 million. So if you put both of them together and then look at the global burden of glaucoma, in 2020, these were the figures. The global prevalence of blindness due to glaucoma, the disease that we saw right now, the global prevalence of blindness due to it in the age group of more than 50 years is about 36.6 million. The majority of chunk is occupied by cataract, and glaucoma contributes to 11% of the blindness. But remember, the blindness due to cataract is treatable and the blindness due to glaucoma is irreversible. The global estimated prevalence of moderate to severe visual impairment due to glaucoma is about 206 million, of which 4.16 million was due to glaucoma. Am I still audible?
Yes, madam.
Right. Please interrupt me if there's any problem.
Sure.
There is a problem already. I'm not able to run through my slides. Okay. So this is the relative contribution of age standard prevalence of blindness due to glaucoma and of moderate to severe visual impairment. So this is extremely high and it becomes more concerning because this blindness is irreversible. So at present, glaucoma is the second leading cause of blindness and fourth leading cause of moderate to severe visual impairment, again, all of which is totally irreversible. And this is only going to grow exponentially, and in the year 2040 they feel this figure will be almost 111.8 million, with Asia and Africa contributing to most of it. Now, why are people still going for blind due to glaucoma? We have so much of technological advances in the diagnosis, advances in the disease process, but still we have many people going blind due to glaucoma. The reason for it is most of the time it is still underdiagnosed. This is because of lack of regular visits of at-risk groups. There is poor awareness of the disease, even in the rural and in the urban setting. Cataract we are able to get rid of the cataract background because it is amenable to mass screening. However, that is not true of glaucoma. So you need more opportunistic screening, and we need comprehensive eye examination at all the mass screenings. Here probably there is a role for teleglaucoma and AI and deep learning systems. Still, glaucoma is being improperly treated. There's always underestimation of the damage, and there's a less aggressive approach in many of the scenarios. And at the same time, there is extensive lack of compliance because this is a disease of a lifetime. You need lifetime treatment and you need lifetime follow-up. So here there is a huge role of patient education so that we can make the patients more compliant and we can prevent patients from going blind to this disease. So I kept talking about a lot more opportunistic screening of the population who is at risk. So who are at risk to develop glaucoma? Remember, glaucoma is an age-related disease. So anybody who is above the age of 40 needs a frequent comprehensive eye examination. You don't just go to the optician and change your pair of glasses. You go through a thorough evaluation of your eye and repeat it at least once in 2 to 3 years. Those who have short-sightedness or myopia, those who have a family history of glaucoma, those who belong to these particular races, those who are chronic smokers, who have systemic blood pressure, diabetes, who have used systemic or local steroids for asthma, for other collagen vascular disorders like arthritis, etc., they are at a higher risk of developing glaucoma. Now, those who have migraine, those who snore a lot at night and have obstructive sleep apnea are again at a very high risk to develop glaucoma. So these are the groups of patients that need to have frequent eye examinations to pick up the disease at the earliest stage. Let's come to the last part of the talk. What are the various environmental factors that we could modify probably? If you look at the prevalence of glaucoma, it is different among different populations. It is high in African nations, low in Eskimos, higher in an urban habitation. This difference can be explained in part due to the difference in genetic background, but there is increasing evidence to show there are also environmental factors which are causing this difference. So hitherto, the only approach that we were using was to target the intraocular pressure so as to save the retinal ganglions. But there might be many lifestyle factors that we can target at this level so as to prevent the progression of the disease or halt the onset of the disease or delay the onset of the disease in the at-risk group. Now, what are the modifiable factors? Factors belonging to your lifestyle and factors like exercise. They will definitely add value to treatment if we can modify this to some extent. So let us run through a few of them. Let us look at each one of them. Smoking. Tobacco smoking, the relationship with progression of the disease is not well elucidated. It's a very complex relationship. It generates a lot of free radicals which cause a lot of inflammation and cell death. At the same time, it has got nicotine, which actually increases the blood flow of the optic nerve and has got a protective effect. That is why I said it's a very, very complex relationship. However, all the evidence shows that cigarette smoking has a negative impact on overall health. Though advice is specifically in glaucoma is not based on strong advice, it is better to avoid smoking in patients in the at-risk groups and those who have disease. There has been a lot of talk about using marijuana for smoking in young glaucoma patients in Europe and America. But the effect of marijuana smoking, it definitely decreases the intraocular pressure, but this effect is very transient, lasts for only 3 to 4 hours. For this, you'll have to smoke marijuana almost 8 to 2 times in a day. So I think you'll be just zonked when you're along with your intraocular pressure being controlled. So at present, the recommendation by the American Glaucoma Society is against its usage because of the short duration. What about alcohol? Again, there is no strong association of alcohol consumption with prevalence of glaucoma. However, chronic alcohol intake causes neurodegeneration in the brain, similarly in the optic nerve. So it is a risk factor for development of glaucoma. But hold on, there is a good news. Red wine has got a lot of flavonoids in it, which has got a protective effect against the development of glaucoma. So cheers, but probably cheers only with red wine. Let's come to exercise. This is probably one of the most important lifestyle modification that is being practiced right now for a healthier lifestyle. But remember, all exercise is not beneficial in glaucoma, and some of them may actually be harmful and cause the disease to progress. And which are they? This list includes isometric exercises like bench presses. These raise the intrathoracic pressure and hence the intraocular pressure. Again, if you are used to doing long durations of high intensity interval training every day, this again releases a lot of free radicals, causes a lot of oxidative stress in the retinal ganglion cells and can cause the disease to progress. If at all you want to do high intensity interval training, it should be of moderate intensity and only probably 3 times per week. These postures of yoga is the new mantra everywhere. These postures in yoga, the Upasana, the Adho Mukha Swasana, Shirsasana, Viparita, Karnika and Halasana, these are the ones where the head and eyes are at a lower level than the heart. And this increases again the intrathoracic pressure and hence the intraocular pressure, and they are actually harmful if you are an at-risk population of glaucoma or you have glaucoma. Again, pranayams which involve holding the breath, for example, Kapalabhati. This also is a kind of Valsalva maneuver and this can increase the intraocular pressure. Swimming, though, is not dangerous for glaucoma patients, but the goggles which press on the orbit, they can decrease the perfusion pressure inside the eye and this can cause the disease to progress. So the take-home message with exercise is recommended exercises are probably just aerobic exercises like walking. Yoga and pranayama can be done, but exclude all those postures and Kapalabhati the way I have explained. And if at all you want to do high intensity level training, do of moderate intensity and only 3 times a week. Exercise definitely upgrades all the brain derived neurotropic factors. It decreases the oxidative stress at the retinal ganglion cell layer. So definitely it will prevent the progression of glaucoma, except those that I have mentioned before. At the same time, exercise alleviates depression and anxiety because all these patients of glaucoma have the fear of going blind. So it definitely will alleviate this and help them only. There are some yoga and other forms of exercises which are actually can be recommended to all your patients of glaucoma. And one of them is yoga-based ocular exercise, which is called as the Tratak Kriya. Now, what is done in this is you stare continuously at a small object placed a few feet away from you. Stare at it continuously till there is watering from the eye. This causes a contraction and relaxation of a ciliary muscle in the eye and actually improves the drainage of that fluid that I talked about, and that decreases the intraocular pressure. Yogic pranayama with diaphragmatic breathing. You are not holding the breathing, but you are doing diaphragmatic breathing. This regulates the autonomic system because it stimulates the parasympathetic system, and this actually is beneficial for the eye in glaucoma. Mindfulness-based meditation, if done for 30 minutes every day, this decreases the intraocular pressure, it increases the blood flow both to the brain and the optic nerve, and at the same time it increases the parasympathetic activity. It also decreases the stress hormones and the cortisol level, and in all these mechanisms it helps to control the pressure and the damage due to glaucoma. This is as far as exercise goes. Now let us come to diet and glaucoma. Again, the role of dietary supplements in prevention of progression. The results are very conflicting and very inconclusive in literature. But just let me highlight a few of them. Flavonoids are plant-based polyphenols that are found in dark chocolate, red wine, berries, citrus foods, and tree. They don't influence the intraocular pressures directly, but they maintain or help to improve the visual field. So they have some sort of neuroprotective effect, not only in the eye, but also in these set of ocular blood flow levels. Coffee has got, now these flavonoids are present in tea, they're not present in coffee. Again, coffee has more caffeine than tea, but what coffee also has is a lot of hydroxycinamic acids. Every cup of coffee actually increases the intraocular pressure by 1 millimeter, though the effect is extremely transient. However, the hydroxycinamic acids which are there in coffee, they decrease the hypoxia-related damage. Again, two contrasting effects like tobacco. So what do? All your glaucoma patients, tell them to maintain the glaucoma habits in moderation. And if the disease is progressing and if the patient is a heavy coffee drinker, to decrease the intake so that we decrease this rise in pressure. Green leafy vegetables are a good source of nitrates, and these release nitric oxide on ingestion. Nitric oxide is something that increases the blood flow everywhere, in the brain, in the eye, and hence allows us to increase the drainage of the fluid of the eye also. So it has definitely a protective effect in glaucoma patients. Omega-3 fatty acids, which has been found in flaxseed oil, fish oil, and walnuts. Again, this sort of modulates the ocular circulation. However, its benefit in glaucoma is controversial at this point. So vitamins can be a part of your healthy diet. There is no direct evidence to support vitamin supplementation in the treatment of glaucoma. Just recently, however, there has been a study where they've used vitamin B3 in diets of mice with glaucoma, and they found that the retinal function improves. However, the dose of vitamin B3 required here was very high. There are a lot of herbal supplements, specific ones like ginkgo biloba and bilberry, which actually show an improvement in the visual field and increase the ocular blood flow. So these can probably be added to the diet. Your sleep position also interferes or influences your pressures inside the eye. Actually, the intraocular pressure increases when you lie down. However, this can be decreased if your head is slightly elevated by a small pillow. What is more important about sleep is for people who snore at night. Now, most people who snore at night, they have something called as obstructive sleep apnea, and this is strongly associated with progression of the disease. So if the patient, or if you are having glaucoma, or if you are at risk for glaucoma and you are snoring at night, then it is wiser to undergo a sleep apnea test. And if your test is positive with a very high score, then just giving simple CPAP therapy will actually improve your ocular perfusion and improve or prevent further damage due to glaucoma. There are other small tips like do not wear very tight neckties. Again, this raises the pressure inside the eye. And there are many people who drink water almost up to 1 liter on an empty stomach on waking up. This is extremely harmful because this really raises the pressure inside the eye. You may drink 3 to 4 liters of water throughout the day, but at any given time, do not drink more than 2 glasses of water. So the take-home points in all these lifestyle modifying factors is all the studies are retrospective, they're cross-sectional and population-based. You really cannot detect you can only detect a possible association, but you cannot prove a cause and effect relationship because these require long-term randomized controlled trials, and many of them are ongoing at this date. So what is probably recommended at this point is have a well-balanced diet with a lot of green leafy vegetables, use some source of flavonoids like tea, citrus fruits, dark chocolate, etc. You can use omega-3 intake in moderation. Heavy caffeine intake should be avoided in the form of coffee. You can do aerobic exercises and at the most 30 minutes of moderate intensity exercises 3 times a week. Try out the newer yogic ocular exercises. Avoid the yoga poses and pranayams that I talked about. Do mindful meditation. Avoid tobacco and marijuana as far as possible. So in conclusion, environmental and lifestyle modifications definitely would help. A comprehensive screening at-risk population, a very effective and timely intervention with either medicines, lasers, surgery when the disease is diagnosed. All these factors are important and play a role in mitigating blindness due to glaucoma. And this is how we probably can preserve our vision and functionality even if we get the disease. Thank you.
Thank you, Dr. Jyoti Shetty, for a very comprehensive and exhaustive coverage of all aspects of glaucoma. It's a wonderful lecture and covering all aspects of glaucoma. How do you proceed now? We'll have some question and answer to start with, and then I will round up at the end. I'll just mentioning something. And participants, if you have any questions, you can direct it to Dr. Jyoti Shetty on any one of the aspects actually she covered in a matter of about 45 minutes. Participants, please.
I have a question, madam. It's
Sure.
a silent thief of sight, glaucoma. I think that is a nickname I remember reading in our medical books. For a layman, what can he do, or what can be the red flags which makes him to go and seek for an eye examination? Because as doctors we understand, but for somebody non-medical.
So I did mention this in the talk. Remember, glaucoma is a disease of the aging eye. You do get glaucoma at birth. You have something called as juvenile open-angle glaucoma, which is seen in early adulthood. but predominantly glaucoma is a disease of the aging eye. So 40 is probably the right age to start with a comprehensive eye examination. What happens at the age of 40, and I'll tell you why 40 is important. At the age of 40, we start getting problems with our near vision. That's probably when we first ever go and get, a pair of glasses, because till that time, can you hear me? Am I audible?
Yes.
Yes, sir.
Yes, ma'am.
Yeah, so that is probably when we go and get our eye examination done for the first time. But what do? We visit an optician, just take a pair of glasses and we go home. But this is where probably you do a comprehensive eye examination with the ophthalmologist so that they look into every aspect. See, an eye examination includes an intraocular pressure measurement, includes a looking at your nerve behind. So if your intraocular pressure is abnormal, it can be picked up. If your nerve is abnormal, it can be picked up. So red flags for open-angle glaucoma, which forms the majority of glaucoma, are from the patient's point of view are very few. It is only when the field is really destroyed that you come to know, okay, there's not something wrong with my eye. That's the reason why I'm saying that if you are at risk, and your risk being the age of 40, you start. Everybody is at risk after the age of 40. If you have a family history of glaucoma, there's somebody in your family who has lost glaucoma, that is a red flag for you. Go and get a comprehensive eye examination done. If you have been on steroids for a long time, there are so many asthmatics on steroids, on inhalers, oral steroids. There's so many arthritis patients on steroids. There are so many diseases where steroids has been used on and off. Again, these people are at risk of developing glaucoma. So visit your ophthalmologist. They can do the needful for you. If you are a diabetic, and not only ruling out diabetic retinopathy, you have a higher risk of glaucoma too. Again, go visit your ophthalmologist. Now, these are they're not red flags, because that's the reason why there are no red flags. It's a disease, which comes through the backflow. However, if you have the other subset of disease, which is the angle closure glaucoma, then there are red flags there. The disease starts with the patient seeing halos around, towards the evening time, when they enter from a lit room to a dark room. They suddenly feel very uncomfortable in the eye. They'll have mild pain, discomfort, mild headache, slight blurring of vision. And at that time, they look at a distant source of light. They might see some colored rings around it. That is a red flag. That is, your angle is closing intermittently. And before it goes into a full disease, you can catch the disease at this stage. Angle closure disease is another subset which has got a very strong family history. So if you have a family history of angle closure disease, please get your eyes examined after 40 every year. I hope that answers all your questions.
But one of the problems is when they go for an eye checkup, many a times it is focusing on whether he needs the glasses or not. Is there a criteria for an ophthalmologist or an optometrist? Most of the nowadays, the high street shops, their agenda is to see whether you need a glass. Is there any criteria or anything like at what age or what sign they should get their IOP or intraocular pressure checked?
After the age of 40, definitely.
Okay.
And believe me, no optician is qualified to check your intraocular pressure or comment on any disease. They are only, in India, they're only allowed to check your glasses. And if they find that they're not able to get your glasses for any reason, then they know that there is something wrong in the eye, they have to refer. But this, of course, as you know, we are a country of jugaads. So we never have, the proper things in place ever. So I think it is left to the patients. You have to be educated enough to know that just checking for the glasses is not enough. I need a thorough eye examination. And I'm sure every ophthalmologist will do a thorough eye examination at every visit. This is part of routine eye examination. This is not something specific that we do. As part of your routine eye examination, this disease can be picked up.
Yeah, thank you, madam. Thank you.
Any more questions?
Madam, coming to you said wine definitely have got antioxidant. Red wine is preferable. You suggested anything in the limit. Anything in the limit.
I don't suggest you have a peg of red wine every day. I just thought I'd cheer all the people who enjoy their drink. So it's everything in moderation, sir.
Yeah, that's what.
If somebody is a chronic drinker, it has got a neurodegenerative effect everywhere in your body. Your brain is also affected. Similarly, your optic nerve is affected. So anything in moderation is absolutely fine. And if you have to choose a drink, then choose red wine.
Okay. Would you say the white wine is preferable? The red wine is most preferable because they got more antioxidant, the white wine. What would you say?
It's the flavonoids that are important, sir. And the flavonoids are available only in red grapes.
Okay.
So that's how the red wine. The black grapes, not the red grapes. The black grapes, and hence the red wine. This is all of wine drinking, I know, sir. I think we'll have to ask a connoisseur of wine to explain further. But what red wine has is flavonoids more than white wine.
Wine is not grapes. Even the grapes, what they use, the red grapes, it can be white wine. Only use the covers in the red wine. The cover is not.
Probably.
Probably.
It's the skin problem. Yeah.
Grapes are the same. Grapes are the same.
What is your choice, Dr. White wine. White wine for him.
Glass of white wine.
Are there any more questions?
Dr. Paramesh, can I ask a question?
Yeah, go ahead, sir, please.
Say, today, all the people are using computers and mobile for a long time. Would that have an effect on the onset of glaucoma?
No direct association, sir. Computers do have a lot of near vision being used with a lot of contraction of the ciliary muscles, which is actually supposed to improve the drainage of aqueous in the eye. But no long-term study to prove this. So there is no cause and effect relationship at all. Heavy computer usage is otherwise even a little, not very beneficial for the eye, as in can cause a lot of problems in other ways. You have a lot of asthenopia, you have a lot of headaches, blurring of vision, other signs and symptoms of computer vision syndrome, but not directly associated with glaucoma at all.
Thank you.
Sir, what I definitely, I hope most people would have taken home is the yoga and the pranayams. We blindly follow the yoga instructors and the pranayam instructors and the people in the gym, and many of these are actually detrimental to you. Especially the breath holding exercises and the positions where you bend down. Those in people who are at risk, like those who have a strong family history of glaucoma, those who are already having mild disease, I think best avoid it. These are factors that are subtly contributing to your disease. We try and control the intraocular pressure, and then we find that the disease is inevitably still progressing. And then when we go back into the history, we realize so many things are working against the eye, which we have not detected on our examinations. So these are the, don't just blindly follow, like this is, you have so many things on the net that we just blindly following. So look at everything very carefully before you jump into all these exercises.
Any more questions? Otherwise, we'll just round it up with a few comments of mine. Okay, thank you very much once again, Dr. Jyoti. I think just to round it up, and am I audible?
Yes, sir.
Yes, sir.
Yeah. Just to round it up, I think certain important issues he started talking about. The first one is the public health perspective in terms of glaucoma. If you go to the and approximately, if you say in terms of prevalence of glaucoma and all eye diseases, you combine cataract and refractive error together, it could be around 60%. Then corneal problems around 15%, and diabetic retinopathy and glaucoma, if you club together, maybe around another 15%, 5% is one. Then comes the back of the retina, that is age-related macular diseases and other things are there. So in terms of public health, in our experience of over almost more than 50 years now, more so when eye screening camps are conducted for cataract surgeries, in spite of our best efforts under the National Program for Control of Blindness, and still people are sending optometrists for screening, and no doctor will be able to attend all the screening camps. sometimes still, that's the one we miss out. Many more cases of cases taken for a kind of an immature cataract or early cataract that's been pushed out. By the time they come back to the next camp, they would have been already half blind. That's where even in the outreach screening camps, what is more important is we'll be able to and then take the intraocular pressure that by non-contact or a portable tonometry is so very important. In every screening camp, we have to check the intraocular pressure because most of them are over the age of 40 years. Then again, opportunistic screening, Dr. Jyoti was mentioning about every presbyopic patient, because we have always tendency for going into an autorefractometer, going to an optometrist. When compared to developing and the countries, especially in UK, you understand that there we have ophthalmic opticians. When you say ophthalmic opticians, as against paramedical ophthalmic assistants or our refractionists or optometrists, they are trained in doing ophthalmoscopy and checking the intraocular and then pressure. Even any actually recognized optician there, ophthalmic optician, generally they check the intraocular pressure, have a look at the back of the eye to look for certain changes in the retina. That's why they don't miss out. And in developing countries, especially in UK and Europe, they do have a glaucoma screening program is there that is called as population-based screening, but it is not cost effective. It's not cost effective. It is prohibitively actually and costly that cannot be actually and executed in our country or the underdeveloped countries. Then she talked about the ethnicity. In terms of ethnicity, of course, African eyes and heavily pigmented actually iris is there. That the debris in case of trabecular meshwork will be more. They are more prone for open angle glaucoma, and when compared to the Asians, they are more prone for the angle closure glaucoma. That's what we have to keep it in mind. These are the certain issues taught. Then, in terms of education, public health and education, there very important is the family history. Apart from ethnicity, we have the family history. Whether you can say this glaucoma has got any hereditary background, either dominant or recessive, or it should be X-linked. Probably it runs in families. All those people who have got the actual family history, they should be extra cautious to take care of the check the intraocular pressure. Then some other one or two terms, what is called as, we call it as ocular hypertension. That means only intraocular pressure is high without damaging to the optic nerve head or any field changes are there. And it could be due to some transitory one. At the same time, we call certain terms as normotensive glaucoma or sometimes, hypotensive glaucoma. Mostly where as the result of chronic actually neuropathy, optic neuropathy, and without any intraocular pressure rise. Sometimes they almost look like each one like that. I think these are the ones in treatment, because in terms of medical line of treatment, the whole principle is all those drugs which reduce the actually inflow of aqueous, all those drugs which increase the outflow of the aqueous. There are some drugs which do both. They reduce the inflow and increase the outflow also. Always we try with one drug medicine, then not controlled, you can add one more, you can add one more. Not controlled, you can opt for surgery. But what is important is compliance for medical line of treatment is so very important. It's very, very difficult to and then comply lifelong. And the cost of treatment for our patients in such cases, and I think especially in African countries, we will use the primarily actually surgery as the primary way of treatment, because either due to cost or due to non-compliance, better to actually have this surgery has been practiced in certain countries, especially African countries. And for risk factors, she has very well and then explained all the risk factors, especially in terms of actually very high myopia or diabetes, all the things she has been covered, and then good and bad effects of alcohol and different types of wines also she covered, and the diet, and then the meditation and the stress relief. So what is more important is in terms of public health, the most important is this is irreversible blindness versus cataract is reversible blindness. And keeping that in mind, we have to give more importance, especially opportunistic screening in terms of all cataract screening, all people who are coming for a presbyopic or the reading glasses, wherever you do diabetic retinopathy screening, I think these are the opportunities we should not miss on. In every screening camp, it should be mandatorily, if the patient is over the age of 40 years, I think you have to have a non-contact tonometer. We'll be able to check the pressure. I think with these comments, I once again thank Dr. Jyoti Shetty for a very exhaustive and then very, very important presentation she has made. And then back to Dr. Parvesh. Thank you very much.
I think wonderful, sir. It was really very good. And maybe I have to, can I ask one question now?
Go ahead, please.
Sure, sir.
Well, I think most of the, especially persistent asthma is increasing in Bangalore. Be careful if all are related to that. Most of them are in inhaled steroid. Would you say it is inhaled steroid usually effect is much less dose reaction? You mean to say the oral steroid, what you are giving, or the inhaled steroid?
So oral and intravenous steroids definitely raise pressures is a high risk factor. Now, inhalational steroids have undergone a lot of changes. If you look at the doses, the metered doses that is being given has come down quite a lot. There are very good inhalational steroids now, and very, very targeted and metered dosages are being given. This over some period of time is not harmful, but over long period of times with lot of dosaging required in the day can raise the intraocular pressure in susceptible populations. I'm also talking about local steroids in the form of drops also. Apart from the ones that we're talking about, inhalational steroids in asthma. Many of the patients with asthma also have seasonal allergic conjunctivitis, and all of them use topical steroids for their eyes. Yes. And these are indiscriminately used by patients. You know, you prescribe them once, they get relief, and the next time they don't see you. They just go and buy it by themselves because they know that this drop works. Just they would probably pick up a inhaler from the counter. And these are the drops that raise the intraocular pressures to dramatic levels when used in susceptible population over a long period of time. So asthma that way, if it is associated with seasonal allergic conjunctivitis and they are using topical steroid drops, we have seen a high incidence of glaucoma in them.
Well, now, as you rightly said, the upper airway allergy is becoming more and more now with the STM10 molecule.
Eye allergy.
Yes, eye allergy. That's why we call allergic rhinoconjunctivitis. We together added.
True.
Most of them are on steroid. That's what we have to be cautious about those things. Yes. I think that's a good information. And also, you said about the sleep apnea syndrome in children. Only 8% of the children, because we had to ask the parent. Nobody answers that. If I ask the 8% children who had a chronic cough more than 2 weeks, nearly the 27% have that one. Sleep disorder breathing, and in that 1.5% is the obstructive sleep apnea syndrome. So in children is not that high, but definitely keep it in mind.
Yeah. So what I'm talking about, obstructive sleep apnea in adults, in children it's not been studied at all because the incidence, you don't see this obstructive sleep apnea causes or is highly associated with normotensive glaucoma, sir. If you remember what Dr. Chandrasekhar, I didn't touch on that because I thought that would be, way beyond the crowd that too technical for the crowd that I was addressing. In normotensive glaucoma, you have damage of the optic nerve, which simulates the damage which occurs with high pressures, but the pressures are normal. If you look at the normal pressure range, I said it is between 10 to 21, but here even a pressure of 10, 12, 13 is harmful to the patient. There is progressive damage that is occurring in the nerve. So it is not all pressure related, but our understanding of glaucoma up till now has been that we can only treat the intraocular pressure. So in every patient, we just decrease the intraocular pressure, but in these people, the damage continues because there are various other factors which affect the blood flow of the optic nerve, the local neuroprotective. There's so many other factors that are affected which cause a progressive damage and which have not been understood very well to this day. And this is where obstructive sleep apnea plays a role. It decreases the perfusion pressure of the optic nerve and goes on prolonging the damage there. The other thing about obstructive sleep apnea that was very interesting in normotensive glaucoma is it has also been associated to a particular gene. There's a lot of genetic work being done. Normotensive glaucoma has also been linked to a genetic background. If you look at the genetic this susceptibility of the disease in glaucoma, it's very complicated. There are the autosomal dominant is only the congenital and the juvenile open angle glaucoma, which can be traced through the myocilin gene. In normotensive glaucoma, they found another optineurin, which has got a strong association gene, and these people, they have a strong association of obstructive sleep apnea too. So that's how it becomes very, very important. And we are seeing 40-year-olds, 45-year-olds, which is not really the age group for normotensive glaucoma, but they come with normotensive glaucoma. They progress like glaucoma. And then you go and do their obstructive sleep apnea test. They are definitely, there's something called as, you will be aware of it, the AHI index, the apnea-hypoapnea index. High hypoapnea, I've seen indexes of 25, 26, 30. And you just treat them with CPAP. And over a period of time, you will see that, actually the visual field is improving and there's a control in progression of the disease. So it forms a very important part of people who are at risk and who are having disease and we are not able to control it. There's something more that's adding to it.
Okay. Thank you very much. So I think I will request Dr. Ravi Kumar, Secretary of the CONHAD India chapter, to give the vote of thanks and appreciating. We really enjoyed the talk and the comments, and our chairman is excellent. Ravi, over to you.
Yeah. Sorry. Hi, everyone. Thank you very much for joining us. It's been once again a remarkable start for 2022. This is our 13th monthly program, second year in running, and thanks to Dr. Paramesh for carrying out such a interesting program. Dr. Jyoti Shetty, thank you very much for your time. It was wonderful to hear from you. And I hope the general audience, majority of general audience, non-medical, I hope it's been very helpful for them to understand this. I'm pretty sure everybody in their family will have somebody's 40 and above. I hope you'll all make sure that they get one, at least one annual eye checkup. Would you say, madam?
True.
One annual eye checkup from an ophthalmologist.
Yeah. At least once in 2 years, I think 2 to 3 years is fair enough. It's absolutely fair enough.
Okay. I think that will be very helpful, and the message will go to their homes. I hope they will all take it up seriously. Sir, Dr. Jayavajira Bandila.
Illa Bandila.
Okay. Next is Dr. Shetty, of the Vice Chancellor from Aditya Chinchingiri University. It's been always been very supportive for us, and is a very good friend of Dr. Paramesh. We had many interactions. Thank you very much, sir. I think this is another topic very close to you. I would like to thank Indian Institute of Science and also the IT support team for helping us out to carry out this program month on month. And thank you, everyone. And it's been a great evening. We look forward to the next meeting, and we'll let you know very soon.
So before concluding, with your permission, we put this talk in the YouTube. That is, go to all the CONHAD members of the 54 countries, UK, USA, Canada, and Australia. With the permission, madam, we'll put this talk.
Sure. Absolutely.
Thank you very much.
Thank you, everyone.
Thank you. And thank you, Dr. Paramesh. I'm seeing Dr. Chandrasekhar Shetty after a long time. Thank you for the honor.
Thank you, Jyoti.
And our professor